Hi. Hi, everyone. So, yeah, I'm feeling nervous and I don't have Alistair's excuse other than I have children who've not let me sleep tonight because one of them's going through a sleep regression. So feel sorry for me if I forget my words or get stuck. Okay. So, I was asked to talk about my experience as a neuropsychologist and what we can provide from the very acute stages to more the community stages. And that's mainly because I am split across multiple roles. So I am part-time a neuropsychologist for the major trauma and the Department of Clinical Neurosciences. I'm also a research fellow, which means that essentially I have about a day a week or so to do research into certain conditions. My specialism is social cognition and also confusion, post-acute confusion. So the likes of delirium and PTA and so on, and disorders of consciousness as well. I'm also a director, or co-director actually, of Edinburgh Neuropsychology, and we have a little stand out there with my colleague Dr. Sarah Gerlanders, who's also a neuropsychologist. And I'm also part-time, however you fit that, I'm an associate lecturer for some of the universities. So what is neuropsychology? I really should know this. We are clinical psychologists who have a bit more specific knowledge, or I should say more than a bit more, in neurological conditions. So we've specialized as clinical psychologists and we've gone on to do further training, further examinations, further work, and further experience, years of experience in the area of neurological conditions. And we are registered within there's specialist registers for that. And okay, so that's how we get there. So what do we do? So we look at the relationship between a person's thinking abilities, how they're feeling, their emotions, their behavior, etc. And we work across a number of services, and hopefully I'll cover some of those now. And we can provide therapy, we can provide CBT, ACT, EMDR, we can provide support for families as well, around living with the consequences of brain injuries. We can provide assessments of someone's thinking abilities, assessments of people's abilities, I'm not sure where to stand, looking at their strengths, their weaknesses, looking at, for instance, the effects of medication, or looking at whether there's improvement or decline over time. So I'm really going to focus around my work around moderate to severe, but I thought I should also point out I've got a couple of slides just around mild and concussion, mild TBI and concussion. And it's because most of the TBIs that occur each year are mild TBIs or they're concussions. And essentially they're bumps or jolts to the brain or and they can cause symptoms like they can affect how a person thinks, how they learn, how they act. They can affect their sleep, their fatigue, and in the overwhelming majority of cases, those symptoms do improve with time. But there are times when actually, however many weeks or months down the line, those symptoms still persist. And some people have gone on to term the term post-concussion syndrome. And there are various definitions in the ICD and the DSM around what what it is, but I should also kind of highlight that, a lot of the times people also present with other chronic conditions, and there are orthopedic injuries and pain and headaches and potentially mental health difficulties as well, and they kind of share some symptoms in common. But all this to actually say that the evidence out there is that things like a graded physical training, cognitive and cognitive behavioral therapy, anxiety strategies, and so on are the evidence out there. And as neuropsychologists, that should be our bread and butter. So supporting the person with their fatigue, supporting the person with their sleep, with their mood, with their new identity, with some of the difficulties that they are having. And the thing to say is that I was trying to think why I'm focusing mainly in severe, and it's mainly because from an NHS perspective, if I put my NHS hat on, we tend to see the more moderate to severe, mainly. We are a small team, we're a small service, and so we focus our resources on the more moderate to severe, which means that from a private perspective, we're seeing much more of those mild TBIs and those concussions. So it's quite an interesting mix that I get to see. So let's focus on the more kind of moderate to severe TBIs and what myself as a neuropsychologist or my professional group, what can we offer, how can we help? And these are those injuries where there has been a loss of consciousness of more than, so they've been knocked out and didn't have consciousness for more than 24 hours, or there are bleeds in the brain, as Alistair was talking about, etc. Or they have what they call a period of PTA, post-traumatic amnesia, for however long. And I kind of thought I would have a look at what some of the context around, who are those moderate to severe traumatic brain injury people that come through our service, and what are some of the reasons why we are seeing those people, and what's happened to them, and what's going on around. And actually, one of the most common reasons for a TBI in Lothian, and when I looked at the STAG and TARN data, those are the audit services for major traumas across the UK, it kind of fits that one of the most common reasons for TBI, for admission, is a fall from standing. Now it can be, I think all of us are going to start thinking, oh, well, who falls from standing? And, we'll see in the next stages what the age range and how that has changed through the years as well. Followed by a bigger fall from height, either workplace accidents or jumping or so, and then followed by RTAs, road traffic accidents. And so I kind of had a look a little bit at age and demographics of who we were seeing, and unsurprisingly, it does tend to be overwhelmingly men. It tends to be 2/3 men, 1/3 females. And what we're seeing, if we compare it to previous studies, etc., and previous data from major traumas, is that the mean age is increasing. So we're beginning to see older individuals coming and having traumatic brain injuries in the moderate to severe range, whilst before we used to get the 18, 19, 20-something year olds, we're beginning to see a shift in that. I think it's also fair to say that particularly, I think here in Lothian, I've only got data for Lothian here, is what we're seeing is that around 40% there is also a history of substance abuse, there's also a history of alcohol abuse, and there's also comorbid mental health difficulties. And I think that's important because I think that the kind of the crux of my talk, if anything, is going to be, can we start looking at TBI more as a chronic condition, and the support that we can provide in the community for that. And again, this is quite an interesting slide because I wanted to have a look at where do those moderate to severe, we're talking moderate to severe TBIs, where do they end up? And the vast majority, about 60% go home. And I think it's safe to say, and I don't think anyone here will, that the services in the community are being squeezed, and it's getting harder to get support. So I think it's just a little bit of a reflection out there of 60% of those moderate to severe are going home, and what services are out there, and is the community equipped for this? I don't have an answer. I don't have an answer. Then I kind of, there's this little, it's a nice little study that Downing and colleagues just a few years ago put together to look at what are the kind of typical challenges that individuals who suffered a moderate to severe TBI and their families experience, through their recovery journey. And there are some that, as we can see, are I feel if I look out, you won't hear me, that are common across the entire recovery journey. That kind of, we feel that there's a lack of information, poor communication, etc. But there are some that are specific to specific stages. And myself as a neuropsychologist, that's what I am interested in making sure I am providing a tailored approach to the families and the individual at the different stages. So for the more acute, it tends to be around best interest decisions. There's loads of complex decisions that need to be made at the very acute stage. There's also a lot around for instance, the post-confusional stage. There's a period after a traumatic brain injury where people might be confused, and it can be prolonged. And family find it very difficult, and at times when the individual comes out, they might say, oh my goodness, what did I say? And they're finding it very difficult to deal with the fact that perhaps they don't remember, or the way that they behaved, etc. So there's a lot of work that needs to happen at that stages. Whilst we kind of see at the more, once they've been discharged and in the community, then issues around compensation, issues around support and community services availability, those become, and they're practical issues, and they are big stressors in people's life, and it's supporting them through all of that as well, and understanding how they affect the individual. Okay, so what do I actually do? So currently I'm based in my NHS work, I'm based in the very, very acute. So I'm based in what's called ICU, and I'm based in the Department of Neurosciences, seeing people who have been admitted and seeing their relatives. In ICU, there is a lot of, as I said, best interest meetings, decisions around what's going to happen and the care of the individual, supporting the family through all of that, which is really difficult. Once sedation, ventilation, once those things are lifted, then there are kind of two routes. One is, what if the person, wakes up, but what if they don't? And that's when we might come in and we might start doing joint assessments. I usually work with Alistair. Joint assessments around disorders of consciousness, around, looking at what behavioral repertoire that person is giving me, what do these behaviors signify, and where can we lead that rehabilitation. Supporting the family as well, knowing what the person likes, what's their music, because they will invariably react better to some sort of music than the other. I stupidly used, I couldn't think of any other song. I used Celine Dion's Your Heart Will Go On a young guy who clearly did not react to any of that. We did an assessment together and asked the parents invariably what they like. It was rap music. So, but it's more getting to know the individual and getting to know their likes and dislikes, so we can tailor a little bit how we can get a response. Now, there are cases when the person, following extubation, ventilation, sedation, they start to wake up. There's a period of confusion, and we might measure that. We might look at how prolonged that is and whether this is stabilizing, whether it's still fluctuating. Those are all markers of severity that we need to take into account when we're planning our rehab. We might put some guidelines in place along making sure the patient is safe. How can we help the person that is very confused and disorientated? How can we, support the relatives around that? And then it might be that following that period of confusion, we start pressing them a bit more and doing things like screens. I might come to you and say, I'm going to ask you some questions about your memory. I'm going to ask you some questions. I'm going to ask you to tell me what a few things are. I'm going to ask you words that begin with a certain letter in a minute, etc., etc. And that, again, gives us markers of recovery as well. Other things will be also, there's been a traumatic event. There can be post-acute stress reactions. There can be difficult family dynamics. There can be a whole range of mental health difficulties as well. And not to forget, you're in hospital. You're kind of you're not in control. Things are happening to you. There are routines that are imposed on you, and that can be very difficult on the individual. So I think I've kind of covered that a little bit, but this is a wonderful document that the Black Stork charity put together. It's mainly focusing on major trauma, but it does touch and it takes into account TBI as well. But it looks at what the gold standard rehabilitation should look like, what we should be including, and as well as the physical recovery and the physical therapies, and there should be family support, there should be a focus as well on the person's mental health. And this is just a very busy slide, and I'm not expecting you, but it's literally just to say that sometimes when I meet some of the people in the wards, they'll say, oh, you just see me as a date of birth, or you just see me as a KI number. And I try and explain that we try not to. We might all come from different angles. Your speech and language therapist will be more in looking at potentially your swallowing or your communication, making sure that that's effective. Looking at your language. Your occupational therapy is going to be looking at how you're doing in day-to-day. What is it going to look like if your goal is to return to work? Can you be safe at home? Your physiotherapist might be looking at your mobility and how you're going to be moving around. So we might all come, but we are all looking at you as we're trying to put all that information together. You are a person, you're not just a date of birth or a KI number. And often we might be the ones that kind of bring all that information together to try and make sense. And we also interested in how was the person before? What did they like? What were they like? What sense of humor did they have? What were their values? What is important to them? Because that clearly is going to have an impact on what the rehabilitation is going to look like. And we often, once a patient, usually they're with us for an average of about 3 weeks, and then they're discharged, and most of them will get discharged home. We've put some information and signposting together to just offer them that. Unfortunately, we don't have the scope to follow them up in the community, which again highlights an issue there. But some of our neuropsych colleagues in the communities sometimes are able to pick some of that up. And I guess this is probably the most important slide for me. And it was an article that was recently, 2023, I think, published at the Lancet of Neurology, and it said around the fact that we need to change our view to seeing TBI more of a chronic condition. And essentially, in their review, they suggest that historically, TBI has always kind of been looked at as an injury event with a finite recovery. You have an event, you recover. However, that's not quite the case, and I think we should be moving towards seeing TBI more of a chronic condition, because there are a lot of comorbid presentation, comorbid things that can happen. So I think if I just how did I do it? So we know, for instance, that there is a higher risk of epilepsy, and there might be seizures that are happening that might render the person to come back into the community, might mean that they're not able to return to drive, that might impact in their well-being. There are significant issues with sleep and fatigue. About 40% of people in the community report fatigue issues. That might again have an impact on what they can and cannot engage. Their mood. There are significant difficulties with mood, with self-identity, how they see themselves after the injury. With how others see themselves, with you know, it's kind of their whole self. Well, I was this, you know, exercise mad person, and now I'm not able to do that. Who am I? Substance use. We know that in the initial stages following discharge that reduces, but actually it goes back up again after after a few weeks, a few months, after time. And not only that, but then there's been a traumatic brain injury, which Alistair has made reference to the fact that, you know, there's that executive function, that problem solving, decision making, judgment. So you have someone who potentially had difficulties before with substance use, who now in addition has a brain injury with those difficulties. How difficult is it going to be for that person to then be able to, you know, stay off afterwards? I think we need to be conscious of all of those things, and there is a risk of rehospitalization as well. You know, the study was showing that there was a significant number of people that were being rehospitalized for other reasons. So I think we need to start looking at TBI more as a chronic condition. So if you take anything from today, is that. So let's have a look a little bit at community and what are some of the areas where sometimes we can be involved with. So with regards to return to work, again, a nice little study by Leibson back in 2018, and they looked at some of the factors that affect return to work, because actually I think it's around 45% that the statistic is out there of people after a moderate to severe TBI that return to work. What they don't look at is how many people stay at work, because they return to work, there's a bit of a honeymoon period, and then after time they see that their fatigue, their sleep difficulties, their mood, a whole range of factors, they can't sustain their employment, and then mood declines, etc., and they stop working. So, you know, I think we need to look at trying to support those individuals better, and our job a lot of the time as neuropsychologists would be to potentially focus on the more client-focused work around their motivation, around their values, around their goals, around their thinking abilities and what they can and cannot do, and work closely with our OTs, with our occupational health colleagues around supporting that individual there. And I wanted to get what was the definition that was approved for vocational rehab, and so I looked at the Vocational Rehab Association, and this is what they came out: any process that enables a persons with functional, psychological, developmental, cognitive, and emotional. So you can clearly see that there's a role for a neuropsychologist there. And again, the same with driving. We know that there's a whole bunch of functions that we need in order to safely drive. And, you know, we might be involved not only with the assessment, but also where, for instance, a person might have taken a driving assessment, may have failed the driving assessment, and then it's however many years down the line, they feel that they've improved, the family feel that they've improved, and they contact the DVLA, and the DVLA say, well, actually show me proof. And our role sometimes is providing that, you know, repeat assessment with collateral information, etc., to look at, jointly with other colleagues, to look at whether we should then reconsider that person for a driving assessment. We are often also asked around decisions around capacity. And this is a tricky one, but we might be asked around powers of attorney and guardianship and things like that. And I guess I've put this slide up just to highlight the fact that as neuropsychologists, yes, we might be involved with a capacity assessment and so on. But we are more than just psychometricians. We are more than just looking at the scores. And that's because we have things like what is out there, the frontal lobe paradox. And it means that people might actually do really well in standalone assessments. You might sit them and do really complex assessments, and they might do okay-ish, and then you hear your OT colleagues or you hear the family saying, oh, no, they've left the tap on, they've left the hob on however many times, I cannot have them in the kitchen. I mean, no, you say that they're good planning abilities or they're good, but that's not the case, So we are, and you know, there's this thing called the frontal lobe paradox, and we are fully aware, and I guess we are, we don't just focus on the scores. We don't just focus on the tests. We take the whole person. We take the collateral. We take all of that. And some that, you know, it's becoming more and more relevant is that, you know, we're kind of in, it's a growing field in the area of neuropsychology, and that's because I have recently been asked a couple of times around, is it safe for this person to engage, you know, to have their mobile phones? Yes, no, what do we do? I don't know. And it's a growing field, and there's not much evidence out there, and there's not much support out there either. You know, we are talking about people who potentially can be vulnerable, but if any of you or some of you may have spent time in hospital, I can certainly say, I don't know what I would do without my phone, because it's a little window to the outside world, and you do your shopping, you do your, you know, your banking, you do your, whatever it is, Amazon, you know, I mean, so you do all of it through that, but then I think there is a role for us to be looking at, you know, making sure that person is safe, making sure that they have you know, a good understanding of their vulnerabilities and what they put out there about themselves, about other people, how they engage, I mean, dating and things like that. You know, I think it's important, and I think we do have a role. I just don't have an answer just yet. So, my final slide. So, this is a really old kind of study. It's 2012 that kind of looked at how useful are neuropsychologists. And I think hopefully you've seen that we can work with people in different ways. We can do standalone assessments, so that might be for assessment for treatment report for case managers or expert witness, or it might be for rehab purposes, looking at the person's strengths and weaknesses, or capacity assessments and so on. We can also provide therapy, different types of therapy, you know, to deal with the acute reactions that happen, or all the comorbidities and everything else that's going on in their lives, and all the challenges that are going on, and support for the families and so on. And I think one thing is to say that, you know, even though some of the assessments, you know, I think I was trying to have a think about, are assessments still relevant, you know, paper and pencil, and a lot of those are evolving. Who would have thought a few years ago that we would be doing things via iPads and remote and things like that? Things are evolving, but at the core, our skills are still valuable and are still there. So hopefully this talk has given you just a little flavor of what we do, how we might help, and if some of you have come across us, hopefully that's in line with what you were thinking. So yeah, thank you very much.
Thank you, Dr. Poveda. So we will have time for just a quick question. Now, I think there should be a fancy mic that's a way to appear that will come to you if you have a question. So can you pop your hand up if there's anything you would like to ask Dr. Poveda? Might be a lucky escape. No questions? Oh, yes, we've got one. If you could just pop your hand right up and we'll get the mic over to you.
Yes.
Thanks. So you'd said about that there wasn't any follow-up in the community at all, and there was a gap. Is there any follow-up from any other person in your team at all for when they're discharged and they go home? Is there any service that kind of picks up when people are at home?
From a neuropsychology perspective?
Or anyone that is part of the MDT team at all? Is there anything at all?
Yeah, part of the MDT team, there are some support services out there, locality specific. But from a neuropsychology perspective, we have the general neuropsychology who will pick some of them, but they're usually then referred back to them. We ourselves don't follow them up from the very acute. Our role, my role, as the major trauma one, would stop at the point of discharge. But you've got community nurses and you've got OTs and you've got a little bit of neuropsych out there that can help. Locality specific, and it's all evolving and changing. Okay.
Thank you.
Thank you.